Hello and greetings from Detroit, where we have lots of COVID-19. We're sorry that you couldn't come join us, but right now it's probably not the best place in the world to be. We're happy to have this symposium though, online. It's better than not having it at all. I'm at Henry Ford Hospital in Detroit, where I work with Dr. Mayerhoff, who's also speaking, where Dr. Benninger started doing Botox injections probably back in the early 1990s, and we've been doing it ever since. First of all, I have no disclosures, except that this is the first time I'm wearing a dress shirt in over a month. So my talk today, I'm going to do a brief, and this will be brief, review of spasmodic dysphonia with focus on adductor, that is ADD, spasmodic dysphonia. I'll talk about the mechanism of action of Botox, the routes of injections, and then we'll talk about unilateral versus bilateral injections, and then talk about dosage and adjustment of dosage over time. So this will mostly be fairly practical talk, not too much research here. So as most of you know, because you're all pretty well educated on this, spasmodic dysphonia is a task-specific focal laryngeal dystonia, so a movement disorder. There's irregular, uncontrolled voice breaks, depending on the type of spasmodic dysphonia you have. We don't truly understand the pathophysiology, but it starts in the brain, and we are mostly focused on the end organ, which are the vocal folds. In 1871, Traub described this nervous hoarseness. Schnitzler coined the phrase spastic dysphonia back in 1875, and Critchley in 1939 used a similar phrase. It predominantly affects females at about a 2-to-1 ratio. My own practice, it's a much higher female to male ratio. It could be gradual onset, or it can be sudden after a fairly traumatic event, whether a physical or emotional trauma. And most patients have adductor spasmodic dysphonia. About 10% have abductor, and then there's an unclear number who have a mixed adductor-abductor. Dr. Mayerhoff will be talking about the non-adductors, so I won't touch too much on that. So a dystonia is a movement disorder. The most common focal dystonias are cervical dystonia, which is torticollis, which affects the sternocleidomastoid muscle, which you can see me, it's over here on the side. It's a big muscle in the neck that pulls your head off to one side. It's considered a basal ganglia disorder. There's a lot of words on this slide, but to simplify, it's a brain disorder, and the information being transmitted from the brain to the muscles, which are the end organ, is messed up. But we generally focus on the end organ, although deep brain stimulation has been discussed as a possible treatment. But again, I won't be getting into that. This is an excellent review from Christy Ludlow's group at the National Institutes of Health from 2017, talking about how spasmodic dysphonia is a task-specific focal laryngeal dystonia with these irregular breaks. Some of this information I've gone over previously, but they did note that 65% of patients had had measles or mumps, compared to 15% of the national average at the time that the study was done. Also, 30% of these patients have associated the onset of their spasmodic dysphonia with an upper respiratory tract infection, and 21% with a major life stressor. Again, not generally an illness, but a major life stressor. Also, there are more frequent, a greater frequency of writer's cramp in the SD group, 26% versus 4% in a control group. So we see that many patients have a family history of essential tremor, other dystonias in the family. There's some history of meningitis and other neurologic diseases. With regard to genetics, there are 3 genes that have been identified that are related to dystonias, which are listed here on the slide. And again, 15% of patients have a family history of neurologic disorders, and 6% of patients have a family history of a dystonia. However, they have not established a clear link between specific genetics with spasmodic dysphonia to date. So Getting to the end organ, which is the larynx. With adductor spasmodic dysphonia, you have a strained or strangled interruptions in the fluency of voice. And that's due to contractions of the vocalis or thyroarytenoid muscle. That's essentially the same muscle. And those are the major tensors of the vocal folds and adductors, the muscles that pull the vocal folds together, which you see in the upper picture. Also, the lateral cricoarytenoid muscle, which is seen in the lower picture, also pulls the vocal folds together, that is, adducts the vocal folds. So these are the muscles that are mostly involved in adductor spasmodic dysphonia. When we first see patients who are suspected of having adductor spasmodic dysphonia, we look for certain aspects of their history, the gradual onset or a specific traumatic event, waxing and waning, worse with stress, worse with certain situations. Telephone calls, I think, are the most specific to this. Almost all my patients have more trouble talking on the phone than they do when they're talking person to person. And the voice is never completely normal. This is in contrast to muscle tension dysphonia, where patients are using the muscles of their vocal folds incorrectly. It's more of a technique issue. That often has rapid onset, can also be associated with an illness or traumatic event. However, the voice is often completely normal, and it can change really, really quickly. Some patients walk into a room with air conditioning and they lose their voice, which has really no basis in the organic mechanism of the larynx, but it happens, and that's a tip-off to us that it's not spasmodic dysphonia. Tremor is also often associated with spasmodic dysphonia, and sometimes it's hard for us to sort out which is the predominant problem, the tremor or the spasmodic dysphonia. And again, Dr. Mayerhoff will be talking about that in more detail. One of the characteristics that I hear the most from patients is how hard it is to talk. It's effortful. When I hear from patients that it takes a lot of effort to talk, that's also a tip-off to me that it's probably adductor spasmodic dysphonia versus other conditions such as muscle tension dysphonia. And in fact, as the effect of Botox is wearing off, often patients will tell me that the first thing they notice is that it takes more effort to talk, even though they don't hear any difference in the sound of their voice, and certainly others don't hear any difference in the sound of their voice. Also, patients with SD can whisper, which is often a compensatory technique to get around the problem, and often they can sing, as that's less affected than their speaking voice. When we look at patients with spasmodic dysphonia, again, we will hear the voice fluctuating, although it's never really completely normal. When we look at the larynx, we see that they squeeze their vocal folds together tightly at the level of the true vocal folds, which we refer to as the glottis, and not the false vocal folds, which is part of the supraglottis, which you see in the upper picture. You see closure of the true vocal folds and a vibratory cycle. Below that, there's a picture with the false vocal folds here, which tend to squeeze tighter and tighter together during this cycle of phonation. And this is fairly characteristic of muscle tension dysphonia. So when we scope patients with suspected spasmodic dysphonia, that's one of the things we're looking for. Where is the excess tension? With tremor, you can see a tremor even at rest. Skip that. So, what were the treatment options for spasmodic dysphonia prior to, say, 1986? Voice therapy was attempted, but in general, we'll see some improvement with the voice therapy, but it doesn't cure the problem. Systemic medications were tried, such as baclofen and dilantin. There were a variety of surgeries that were done, mostly focused on the recurrent laryngeal nerve, such as cutting the nerve, crushing the nerve, avulsing the nerve, which means to pull it out. There were surgeries on pushing the anterior commissure, which is the front of the vocal folds, back to relax them. But finally, in 1984, this man right here, which is Andy Blitzer, sitting with my mentor, Dr. Bob Ossoff. This picture is from around 2007, I think, Vail, Colorado. Dr. Blitzer and Dr. Brin did the first Botox injections for spasmodic dysphonia. So botulinum toxin type A was first developed by Alan Scott as a treatment for strabismus, which is when the eyes are pulled off to one side by the muscles, the extraocular muscles, which are the muscles that control the position of the eye. And then later they used it for blepharospasm. So I know that all of you who get Botox injections are not happy about having a needle stuck in your neck, but when I think about strabismus and having a needle stuck right up next to your eye, it makes me even more nervous. But in any case, they used it for strabismus and then blepharospasm. It's a potent neurotoxin that blocks communication between the nerve and the muscle that that nerve is attached to. They did their first injections in 1984, and they published this in 1986. The reference is at the bottom of the screen. So botulinum toxin type A, which we call Botox, causes a temporary blockade at the neuromuscular junction. So right here, we see the nerve coming down. This is an axon coming to the nerve. Right in here, there's a presynaptic membrane here, and acetylcholine is released from this, crosses this cleft to the postsynaptic membrane, which is part of the muscle, and then activates the muscle. What Botox does is it blocks the release of the acetylcholine from the nerve, and therefore no communication occurs between the two of them. It's very potent, it's very specific to this particular problem, and it generally has low antigenicity, meaning that it does not cause antibodies to be formed by the immune system. And in fact, antibodies are rarely produced if you're using doses less than 300 units, and typically for the larynx, nobody's using any doses bigger than, say, 15 units, and that's really, really rare. Most doses are less than 4, and most are going to be less than 3, in fact. The effect of Botox can last up to a year afterwards. We also think that it has some modulating effects in the central nervous system. For instance, if you inject the thyroarytenoid muscle, particularly in tremor patients, often we see an effect on other muscles that we have not injected. We really don't completely understand how this works, but it seems to cause some effect on the feedback system between your larynx and your brain. So for adductor spasmodic dysphonia, our target is the thyroarytenoid muscle, which is shown there in red, with the percutaneous cricothyroid approach demonstrated there, and I'll go through all the different approaches. So one way to do it would be flexible laryngoscopy with a sclerotherapy needle going through the mouth with curved needles, and then a variety of percutaneous approaches, and I'll go into detail on each one of these. But first, let's talk a little bit about electromyography, or EMG, which you're going to hear about a little bit as I describe these approaches. So EMG is measuring the electrical activity in muscle. And the way we do that is by sticking a needle, an insulated needle, so the tip of the needle is exposed, the rest of the shaft of the needle is insulated. And that needle is connected to a recording device, which will measure the electrical activity. So when a muscle contracts, there are changes across the membrane of that muscle, and these are electrical changes. And then that electrical change is detected by the needle, amplified by the equipment that the needle is attached to, and it will generate characteristic waveforms. When you're doing diagnostic EMG, which we won't be talking about today, we use instruments such as these with big screens and readouts, and you can record it, and it generates patterns that look like this. For years, I did my Botox injections with a neurologist who brought their cart with their very fancy EMG machines, and they would tell me when it looked like the tip of the needle was in the muscle, but it also generates sound, and I was always listening to the sound, not so much looking at the screen, and I could hear when I was in the muscle. So other instruments have been developed over the years, such as this one, which generates only sound when you're doing the injection. So this is not good for diagnosis, but it tells me when the tip of my needle is in a muscle based on the sound. Some of these small portable units also have a readout, and many of our colleagues around the country still use EMG machines that have visual readouts. When you activate a muscle, This is the type of pattern you will see. And when the muscle is quiet, it'll be a relatively flat line. So the lateral point touch technique is a technique used and championed at UCLA. I have Dr. Blumen's name on there because he was listed as a speaker, but I understand Dr. Burke, who is Dr. Blumen's mentor, will be talking, but this is how Dr. Burke and Dr. Blumen and the various UCLA people do it. They stick a needle through the thyroid cartilage, and I believe, because I don't do it this way, they push a little bit, and when they have a release of the pressure on the syringe, then they know they're through the cartilage and in the muscle, because that's the only thing on the other side of the cartilage. I'm not sure whether they use EMG to confirm that they're in the muscle or not, but they can do that, and then they inject. I personally have trouble with plugging of the needle. Anytime I stick a needle through the cartilage, I don't use this technique. Another way to do it is to come in above the larynx through the thyrohyoid membrane. This requires a longer, stiffer needle. You would need a scope passed through the nose so that you can see where your needle is going. I don't know anybody who actually does Botox injections this way, but it is a technique that we use for other type of injections, and it would be good for someone whose larynx is very low. Sometimes the cricothyroid membrane, which you see here, is sitting so low in the neck you can't even get to it. In fact, it's down in the chest. So this would be a good technique for that, although I have not personally used it for Botox. I've used it for other things. This is the technique that is most commonly used. This is percutaneous, that is through the skin, through the cricothyroid membrane. You come in either at the midline, which is this dotted line is the midline, or a little bit off the midline. You come in, you angle upward and laterally. So this shows an upward angle, angling off to the side, trying to find the thyroid muscle. Most people who do this, and this is how the vast majority of us do it, we use EMG for guidance. It's essentially a blind technique, meaning that we can't see where our needle is going, but we know where the muscles are. We know which way to aim. When we get the tip of the needle into the muscle, then we have the patient say E, and we can hear the activation on our EMG machine, which I'll demonstrate in a minute with a video, which hopefully will play. And then we do our injection. Some people, such as Dr. Ron Tell, who along with his brother were the first to do Botox injections in the state of Michigan, they use a flexible scope passed through the nose, and they use the EMG, and they pass the needle this way. It's a bit more uncomfortable for patients, but it does allow them to be very, very precise every time they inject. They can inject the same spot each time because they're looking every time. I've had patients tell me that they don't really like that technique, but others prefer it that way. And we'll talk about some advantages and disadvantages in a little bit. This can be done, this technique can be done with patients sitting upright or lying supine. Most of us have the patient sitting upright. Most of us stand to the right side of the patient because most of us are right-handed. Others, such as the University of Wisconsin group, championed by Dr. Ford, who is truly one of my heroes, will do this transorally. They use a curved needle like this, and then this is a picture of Dr. Verma demonstrating this technique, where he has a 70-degree telescope in his left hand, the patient's holding her own tongue, and then he's got his needle going through. This shows the view, and the needle's coming down to the vocal fold. Now these pictures are not doing Botox, this is injecting something else, but it just shows the view that they get. This would be the view through a 70-degree telescope. You can also put a flexible scope through the nose, and that'll give you this upper view here, so you can see where your needle is going. This does require much more cooperation from the patients. I think it requires more anesthetic. I watched Dr. Ford do one of these beautifully at one of the workshops in Madison. And of course, Dr. Ford did a great job doing it because he's Dr. Ford. But it did take a while, I have to say, much longer than when I do the percutaneous. Another way to do this is using a flexible scope with a needle that you can pass through the port of the flexible scope. This is a very direct view in that you can see exactly where the needle is being inserted. However, it does require a large volume of the drug to fill the catheter. And likewise, I forgot to mention that it also needs a large volume to fill this entire shaft of the drug. So you end up wasting more, although we end up wasting a lot of drug anyway because of various rules, but we won't go into that. So this is how I do it. So my patient is sitting upright. These are the grounding electrodes that connect to the EMG machine, which I showed you before, that small machine off to the side. And hopefully this will play, and hopefully we'll get some volume. So we try to turn large. We get noise when we enter the lumen, air. Now I'm going to aim up into the left. You can hear the crackling. So when you hear that crackling sound, that means that the tip of the needle is in a muscle that's active, and then you do your injection. Then you back up the needle a little bit and you aim to the right. I do bilateral injections pretty much all the time. So I do the left, then I do the right. I will let you in on a secret. It's probably not a secret to most of you, but sometimes when you're standing on the right side of the patient and you're right-handed, sometimes you will have some trouble injecting the right vocal fold, whereas the left vocal fold is never a problem. I've actually asked many laryngologists over the years if they have the same situation, and those who are humble enough will admit that they in fact do have that problem. Although most of us now, as we've been doing this for now 28 years, it's really unlikely to happen. Oops, there we go. Another way to do this is to sit at the head of the patient with the patient lying down supine. This is how my partner, Dr. Mayerhoff, does it. This is one of our volunteers. It's one of our APPs. And so you see I'm not really using a real needle because she wouldn't volunteer to pose for this if I was using a real needle. One of the advantages of this is I think you're less likely to have trouble hitting one vocal fold over the other because it's a more symmetric way to do this. I don't do it like this. So after we do the injection, what happens? I've told many patients that if they were to wake up in the middle of the night, most of the time their voice would probably be fairly normal. That is the night after they've had their injection. And by the next day, usually they're breathy. Some patients, the breathiness doesn't start until a couple days later. The breathiness can last anywhere from no breathiness at all for some patients to 3 weeks. And if you gave them way too big a dose, it could last much longer than that. You could possibly aspirate thin liquids during that amount of time. And then the good voice, the improved voice, will last anywhere from 2 to 6 months for most patients. There'll be gradual return of spasms over time. Sometimes when someone is stressed out, their voice will get worse for a short period of time, then go back to good. But as the Botox is wearing off, you'll have some return of the spasms. I tell my patients that as soon as they realize that they're getting close to needing it again, they should schedule another follow-up with me. And a more important thing is that over time, we adjust the dose to the patient's response and to the patient's needs and desires. This is a collaborative approach between the physician and the patient. So if I have a patient who has high vocal demands and cannot tolerate any breathiness, and if they live locally, that is at least within an hour of my offices in Detroit, then often we will use a smaller dose and they will get injected more frequently. On the other hand, if I have patients who live in, say, northern Ohio or northern Michigan who are driving 3 hours to get to me, many of those patients will elect to have a larger dose, tolerate the breathiness, but have a longer lasting therapeutic time so that they don't have to make the trip quite so often. And then there are other patients who simply hate the entire experience and really want to stretch it out, the times between injections, so they want to have a bigger dose. Another thought is that you can use unilateral injections and try to establish a pattern to decrease the breathiness, but that does require more frequent injections, depending on how you do it. So this is a survey from 2019 from the group in Southern California. They canvassed 70 laryngologists. 87% of laryngologists do their injections in the office. Some actually do it either in a endoscopy suite or in the operating room, although I find that hard to believe. 88% of those surveyed go through the cricothyroid membrane the way that I demonstrated using EMG guidance, 70% in the sitting position, and 87% start with bilateral injections, starting with 1.25 units bilaterally. So that's a total of 2.5 unit dose. And then they adjust the dose as I described it. This was an interesting study from 2019, and this is from Iran. They had 15 patients where they did an injection. And so most of our patients, of course, are having repeated injections, and we never let the patients get back to their baseline because they, of course, don't want to get back to their baseline. So these were 15 patients who were at their baseline. They had one injection of 2.5 units bilaterally, which is a pretty good dose. And then they were followed with the VAPPP, which is their profile for measuring how their voice affected their lives. They also used the Gerbas scale, which is a scale that speech pathologists and laryngologists will use to judge the quality of the voice. And they tested before the injection, 1 month, 3 months, and 6 months after the injection without doing any more injections. If the patient demanded having another injection, then they dropped out of the study. So these are 15 who were measured beyond 6 months for one single injection. They found that they were still having major positive effects at 3 months, and at 6 months, they were still better than they were pre-injection. This is the VAPPP, and the lower scores are better. This is before the injection. This is 1 month. At 3 months, you see the best effect, the best voice. And here's at 6 months, they're still better than they were at 1 month or at the pre-injection. Of course, everybody is a little bit different. And then this was using the Gerbas scale, which showed pretty much the same thing, that the voices were best at 1 and 3 months, but still better at 6 months than before with regard to roughness and strain. If you do bilateral injections, this is the typical pattern that you see. So if we find this line right here is when we do the injection within a day, your voice is getting better, and probably within 2 days, you're very breathy. And then gradually the breathiness is wearing off. As you get higher, your voice is getting closer to normal. I've just picked the white line as being normal. And then it starts to get spasmodic. Again, say at 4 months, you get your second injection, you drop. So you see this big fluctuation between breathiness and spasmodic voice. Probably it hovers closer to normal for a much longer period. I did this chart a long time ago. Probably should modify it. So another thought is to do unilateral injections. You could either inject one side with the same dose, or you could use the combined dose that you're putting in both vocal folds in just one vocal fold, or you could overlap them. So if you're going to overlap them and you do one vocal fold, so let's say we start off at a baseline, we inject one vocal fold, we get some breathiness. Then at say 2 months, we do the other vocal fold. So this is the left vocal fold. And now as the effect on the right vocal fold is wearing off, the effect on the left vocal fold is kicking in. And you end up with this black line where you don't get these great fluctuations in breathiness and good voice. And hopefully that smooths it out. The disadvantage of doing it this way is that you would have to do the injections more frequently. This is something I did earlier in my career with patients who absolutely could not tolerate the breathiness. I don't really do this anymore. I pretty much just do bilateral injections, but I throw it out there for those people who are really struggling with the breathiness and want to try something else and are willing to have more frequent injections. So this is a study from Dr. Bolamowitz from Washington, that is Washington, D.C. This is a big study where he looked at unilateral versus bilateral injections. There's 4,023 injections, and you can see that about 2/3 of them were bilateral and about 1/3 of them were unilateral. And they looked at the side effects of aspiration and vocal weakness or breathiness, and they looked at the therapeutic effect, that is the good voice. The simple answer to their study is that they found that bilateral injections were more effective on both counts. This is a summary of their results, talking about the people that they did. But the main thing here is to look at table 3. They found that for unilateral patients, 26% of them, the beneficial effect lasted less than a month versus 16% for the bilateral, which was a big difference statistically. For those who were between 1 and 3 months of therapeutic effect, they were more of them were in the bilateral group. And then for those who went beyond 3 months, less than 6 months, again, more in the bilateral group. And then as far as the side effects, there was a little bit of a difference between the unilateral and the bilateral group. But again, there were more side effects in the unilateral group, which frankly was a bit of a surprise. Then we can look at the dosage over time. So this is from Dr. Blitzer's group. And so they looked at all their patients, and Dr. Blitzer has thousands of patients, but they were able to identify 39 patients in that big group who had had injections for a constant 15-year period, all by Dr. Blitzer. So there's no variability between injectors because it's all Dr. Blitzer using the same technique his entire career, which is to inject bilaterally using the technique that I use, which is through the cricothyroid membrane with EMG with no scope. And he found that over time, 41% had needed less Botox over time than they did earlier in their injection career, if you could say that, whereas 59% needed more Botox in the end. So his conclusion was that there is no real trend for the entire group of patients who have adductor spasmodic dysphonia. Some of them will need a little bit less as they get older. Some of them are going to need a little bit older. And really everybody is very individual. This was published in 2016. A few personal observations regarding dosage. One thing is that some patients require a big dose of Botox to see an effect. So I've had patients who have been treated by other excellent laryngologists who have received Botox injections, increasing doses, say up to 2 units to each vocal fold, at which point some laryngologists think, well, that's a pretty big dose for the vocal folds, and they don't go any bigger. And the patient comes to see me, and I thought, okay, let's just go big, and end up injecting, say, 4 units. I have one patient, I think, gets 6 units in each vocal fold, and it works really, really well for that particular patient. So there are patients who might give up because the dosage is, the Botox is not effective because perhaps the dosage just isn't big enough for that particular patient. If you're using 4 or 6 units in each vocal fold, while that's a large dose for the larynx, you have to keep in mind that for other dystonias, sometimes 300 units are being injected. For some patients who get injections to decrease salivation, we will use 100 units in each parotid gland that is up here to decrease their salivation, which is another topic. But the point is that we can use some really, really big doses in people. So 8 units, even 12 units in both vocal folds is really not that big a dose. So don't give up. Try a bigger dose. You really don't have that much to lose. Also, with blind technique, which is the way I do it, our results can be somewhat inconsistent. They can vary. So when I do these injections, I know that I'm not hitting the exact same spot in the muscle each and every time I inject. I know that sometimes I might be 1 millimeter into the muscle, I might be 3 millimeters into the muscle. And this can have variable effects on the vocal folds. However, most patients will tolerate that amount of variability, and so they might have their next injection in, say, 3.5 months, and then the next one 3 months later, and the next one 2.5 months later, but there can be some variability. I do find that people who do the injections using the scope to guide them, such as my neighbor, Dr. Rantel, will often use much smaller doses than I do. I average between 1 unit per vocal fold and 2 units per vocal fold for most of my patients. He'll use sub 1 unit doses. I think Dr. Blitzer also uses smaller than 1 unit doses frequently. But again, I don't think that the difference between 1/2 a unit and 1 unit is really that big a deal. And with the endoscopic approach, also sometimes there's a little bit more consistency because you're always injecting the same part of the vocal. However, I have many patients say they're much happier with the percutaneous technique because they don't like having the scope in their nose when they're having the injection. But patients will pick the technique that works best for them and find the laryngologist who does that technique and live happily ever after. Moving on. So this is a study that we put out in 2001, back when Dr. Benninger, who was at the Cleveland Clinic, was our chair here. And as I said earlier, he started doing Botox in Detroit before I arrived, which was really nice for me. But it just, we studied these using the Voice Handicap Index, showing that patients saw improvement in their VHI, both in how they felt physically, how well they functioned, and how they felt emotionally about their voice. And this was published back in 2001. And I do believe that's all I've got for you. And then hopefully tomorrow we'll be able to do a question and answer period. Tomorrow being Saturday, May 2nd, because you might be watching this on Saturday, May 2nd. So don't tune in on Sunday. Thank you very much. And I want you all to be safe out there and avoid catching nasty viruses. And someday we'll all be able to meet together. Hopefully next year. I understand we're going to have the conference in Detroit. By next year we'll have a vaccine. We'll all be healthy. Life will be good. It'll be great. Thank you very much.